Hello, everyone. I'm Eric Strong from Stanford University and Strong Medicine. Today, in this edition of Underappreciated Diseases, I'm discussing thoracic outlet syndrome. Normally, installments of this series are inspired by patients I've seen, but this one is inspired by the unfortunate news about basketball superstar Victor Wembanyama, affectionately known as Wemby. 2 days ago, Wemby was diagnosed with a DVT, or blood clot, in his shoulder, which is almost certainly referring to his subclavian vein. Now, I don't have access to any of his medical records, and I'm not giving him a diagnosis, but a lot of people have wondered why a young, active, elite athlete would get a blood clot, which is more commonly associated with older, chronically ill, or immobilized individuals. Well, one potential explanation, particularly that given that it occurred in the arm and that he's a basketball player, is something called thoracic outlet syndrome. What is thoracic outlet syndrome? In extreme brief, it is a collection of symptoms and complications caused by compression of the nerves, arteries, or veins within the shoulder. Typically, only one of those three structures is affected in any one patient. Athletes, particularly those who are repetitively lifting their arm over their head, are at an increased risk of developing this. To understand the clinical subtypes and options for treatment, it's necessary to review the relevant anatomy. Here's the shoulder. The relevant bones are the clavicle, the first rib, and the second, third, and fourth. Here is the upper part of the humerus, which is the upper arm. This here is part of the scapula. And right here is the shoulder joint, known to anatomists as the glenohumeral joint, because it attaches the head of the humerus to the glenoid cavity of the scapula, forming a so-called ball and socket joint, which gives the shoulder its high degree of freedom of movement. Although we typically think of the four rotator cuff muscles as the, quote, shoulder muscles, the muscles relevant to thoracic outlet syndrome are actually different. Instead, they include the anterior and middle scalenes. The anterior scalene, middle scalene, and the first rib form the so-called scalene triangle of anatomy in head and neck surgery. Important nerves from the brachial plexus pass through the scalene triangle, as does the subclavian artery, while the subclavian vein passes anterior to the anterior scalene muscle. The nerves, artery, and vein all then pass over the first rib and under the clavicle in a tiny region called the costoclavicular space, and then all three pass deep to the pectoralis minor muscle. These are the three general locations where structures can get compressed: the scalene triangle, the costoclavicular space, and the retropectoralis space. Compression in the retropectoralis space is sometimes referred to as pectoralis minor syndrome, which is sometimes considered to be an anatomic subtype of thoracic outlet syndrome, and other times it's considered to be a closely related but distinct condition, since it's not technically part of the thoracic outlet. Among the three locations, compression in the scalene triangle is the most common. This typically results in nerve-related symptoms such as pain, paresthesias, and/or weakness in the arm, exacerbated by reaching overhead. This complex of symptoms is referred to as neurogenic thoracic outlet syndrome. Compression in the costoclavicular space typically causes compression of the subclavian vein. This manifests as pain, swelling, cyanosis, and heaviness of the affected arm. It also places the patient at high risk of developing a deep vein thrombosis, or DVT. It is also usually seen in individuals with vigorous, repetitive exertion of the upper arms, such as swimmers and baseball, basketball, and volleyball players. This complex of symptoms is referred to as venous thoracic outlet syndrome, and occasionally by the eponym Paget-Schroeder syndrome. Compression in the retropectoralis minor space usually causes neurologic symptoms from compression of the brachial plexus. Lastly is the arterial subtype, in which compression of the subclavian artery is the issue. It is the least common of the three. It results in pain, pallor, paresthesia, and coldness of the arm, similar to patients with upper extremity atherosclerosis. It can also lead to distal arterial embolization. Arterial thoracic outlet syndrome is usually associated with an anatomic abnormality such as an anomalous rib above the first rib, which is referred to as a cervical rib. Here's an antero-posterior cervical spine film that demonstrates the presence of a right cervical rib. Most patients with cervical ribs are asymptomatic and have them discovered incidentally when getting a chest x-ray for some other reason. The mere presence of an extra rib does not equal thoracic outlet syndrome. When it comes to the diagnosis of thoracic outlet syndrome, it requires three basic things: a history consistent with one of the clinical subtypes, a thorough neurological and vascular exam of the affected arm, which also helps to rule out similar conditions, and some form of imaging, which can be duplex ultrasonography of the subclavian vessels, CT angiography for arterial disease, CT venography for venous disease, or MR angiography. It's not unusual for patients to receive more than one imaging modality, particularly patients with high pretest suspicion for venous or arterial disease, in whom the ultrasound was initially negative, as it has a relatively high false negative rate. A chest x-ray can help identify a cervical rib, but it's usually superfluous since most patients end up with a CT or MRI, which would show the same thing. Also notably, some patients with neurogenic thoracic outlet syndrome do not have definitive findings on any imaging. There have been a number of other tests proposed to make the subtypes diagnosis easier and more objective, but there's not yet a consensus around the best strategy. Regarding the differential diagnosis, which refers to the list of other potential explanations for a patient's symptoms, it depends on the clinical subtype. Conditions that can present similarly to neurogenic thoracic outlet syndrome include cervical stenosis and cervical nerve root compression, trauma of the brachial plexus, and any one of the many forms of rotator cuff pathology. Conditions that can present similarly to venous thoracic outlet syndrome would include a spontaneous DVT from a hereditary hypercoagulable state, and those similar to arterial thoracic outlet syndrome include atherosclerosis and an arterial embolism, which can occur as a consequence of atrial fibrillation, an abnormal heart rhythm. Now, let's discuss treatment. It is highly dependent upon the combination of clinical subtype, severity of symptoms, and the anatomic location of compression. Another potential consideration is the individual's profession. A professional athlete whose career was threatened might conceivably choose a procedure with a higher risk but higher reward to maximize the chance of returning to top form, versus someone with an office job who might be content with a more conservative approach, even if 100% recovery was less likely. The specifics of treatment are largely outside the scope of this introductory video, but there's a few very general points. Neurogenic thoracic outlet syndrome should be first managed with physical therapy, but by a therapist familiar with the diagnosis, since some maneuvers or programs could conceivably worsen the condition. Venous thoracic outlet syndrome should be managed with anticoagulation, and those with moderate to severe symptoms should usually receive catheter-directed thrombolysis of any present clots, which means an urgent referral to interventional radiology and/or vascular surgery. And surgery to relieve the compression altogether, which often includes removal of the first rib, is indicated in most patients with the venous or arterial subtypes and in a minority with the neurogenic subtype. The final topic to discuss is prognosis. For those with the venous and arterial subtypes, the majority have resolution of symptoms within months following thrombolysis and/or decompression surgery, although recovery from the neurogenic subtype is more mixed. But even if prognosis is generally good for most people, unfortunately for professional athletes, not everyone returns to top competitive form.